Now question number 1. Which of the following is least useful in bupivacaine induced cardiac toxicity? 20% intralipid emulsion, atropine, epinephrine or amiodarone. Now the local anesthetic induced toxicity basically occurs in two systems, the CNS and the CVS. Why? Because these systems have fast sodium receptors. Now, in the CNS, the patient complains of circumoral numbness, paresthesia of the tongue, then lightheadedness, dizziness, followed by auditory and visual disturbances. For example, the patient will tell you that I have diplopia, or the patient will tell you complain of blurring of vision. So there is auditory and visual disturbances. Patient will complain of tinnitus. This is followed by muscle twitching, tremors and convulsions. Muscle twitching, tremors and convulsions. Now, the treatment for CNS toxicity is small dose of thiopentone or propofol, because they are anticonvulsants. Then secure the airway, benzodiazepines and anticonvulsants. Anticonvulsants are given so that recurrence of the convulsions can be prevented. Benzodiazepines and anticonvulsants, for example lavipril, phenytoin, you can give these drugs. Now what about the cardiovascular toxicity? Now bupivacaine forms irreversible complexes with the receptors of the heart. And therefore should never be given as intravenous injection, and therefore should never be used as intravenous injection. Now, treatment for bupivacaine cardiotoxicity consists of 20% intralipid emulsion. Now, what intralipid emulsion does is it makes the receptor and bupivacaine complex soluble. So, when the receptor and bupivacaine complex becomes soluble, the drug gets dissociated from the receptor binding site. Then you can give atropine, you can give epinephrine and prolonged CPR. Right? Prolonged CPR may be required. Now, as far as amiodarone and lignocaine are concerned, they are not to be used routinely. So they are only given when there is a specific indication for that. Otherwise they are not used. So they are not used routinely. So which of the following is the least useful in bupivacaine induced cardiotoxicity? The answer is D. Amiodarone should not be used routinely along with lignocaine. Both of them are only indicated if there is certain indication for them. Now, next question is, which of the following should not be used topically? So what are the local anesthetic agents which can be used topically? Now, topically used local anesthetic agents are cocaine. It is used as a 4% for eye drops. Cocaine, it is used as 4% for eye drops. Then benzocaine, it is used as a 20% spray. 20% spray for bronchoscopies and endoscopies. It causes high incidence of methglobemia. High incidence of methglobemia can occur with these. Then third is chlorprocaine. Now, chlorprocaine has fastest onset of action. It is not used topically. So chlorprocaine is one drug which is not used topically. Now, then tetracaine. Now, tetracaine is used as a 0.5% solution topically. It is also used for spinal anesthesia. So what are the other drugs besides these drugs which can be used topically? Now, other drugs which can be used topically are lignocaine, prilocaine. These are used for amla cream, 2.5% each. Lignocaine, prilocaine, these are used as for the amla cream, 2.5% each. And debucaine. Debucaine can also be used topically. Right? So, to summarize, topically used local anesthetics are cocaine, benzocaine, tetracaine, lignocaine, prilocaine, and debucaine. So these are the drugs which can be used topically. Now, what about the few points regarding lignocaine? Now, lignocaine is most commonly used local anesthetic. Concentrations used are 0.5% heavy for spinal anesthesia, 0.5% heavy for spinal anesthesia. 5% heavy. 5% heavy for spinal anesthesia, 4% topical anesthesia, 4% topical anesthesia, then 1% for nerve blocks, 1% for nerve blocks, and 0.5% for intravenous regional anesthesia, All of you know that for intravenous regional anesthesia, bupivacaine is contraindicated. Bupivacaine should not be used. So what is the maximum safe dose of lignocaine? Maximum safe dose of lignocaine is 7 milligram per kg body weight with adrenaline and 4.5 milligram per kg body weight without adrenaline. Maximum safe dose is 7 milligram per kg body weight with adrenaline and 4.5 milligram per kg body weight without adrenaline. So answer to question number 2 is C. Chlorprocaine cannot be used topically. Now, question number 3. Induction agent of choice in patients with history of malignant hyperthermia is. Now, in a patient, malignant hyperthermia is a syndrome of rapidly rising temperature. It is a syndrome of rapidly rising temperature which occurs due to abnormality of ryanodine receptors, which cause massive release of calcium from sarcoplasmic reticulum. Triggering factors are succinylcholine, all fluorinated inhalational agents, for example, ether, methoxyfluorine, halothane, isoflurane, enflurane, desflurane, sevoflurane. So all fluorinated inhalational agents including ether and methoxyflurane. Now, so what are the clinical features? Now, clinical features include masseter muscle spasm. This may be the most initial sign in patients susceptible to malignant hyperthermia. Then tachycardia, rise in end-tidal carbon dioxide, metabolic acidosis, then hypertension, then hyperkalemia, hypernatremia, and hyperphosphatemia. Increased phosphorus levels. Then there could be myoglobinuria and renal failure. And rise in temperature. Now, rise in temperature which occurs in malignant hyperthermia is a late sign. It is not an early sign. It is a late sign. So what is the treatment? Now, treatment, it consists of stop all anesthetic agents, because one of your agents is acting as a source. So stop all anesthetic agents, hyperventilate with 100% oxygen. Now, the most definitive treatment is dantrolene 2 milligram per kg, IV every 5 minutes to a maximum dose of 10 milligram per kg. Dantrolene 2 milligram per kg IV every 5 minutes to a maximum dose of 10 milligram per kg. Then soda bicarb soda bicarb, and other symptomatic treatment. For example, you will cool the body, bring down the temperature. Other symptomatic treatment. Other symptomatic treatment. So this is the treatment for malignant hyperthermia. So none of the triggering agent should be used. So which drug is the choice for malignant hyperthermia? It is propofol. Propofol is drug of choice for malignant hyperthermia. Basically you use Tiva. Tiva is a combination of propofol and remifentanil. So we use Tiva in patients with malignant hyperthermia. Now question number 4. Afferent nerves most sensitive to local anesthetic blockade are. So what are the different types of nerves and what are the sensitivity of these nerves to local anesthetic agents? Now all of you know there are 3 types of nerve fibers, A, B and C. Now A, B and C. Now A fibers are again divided into 4 types. A fibers are again divided into 4 types. A alpha. Now A alpha fibers, they are efferent to muscles. And they basically mediate the motor function. On the other hand, A beta fibers are afferent from skin and joints, and they basically mediate tactile and proprioception. Then A delta fibers are efferent to muscle spindles, and they basically mediate the muscle tone. While A gamma fibers, these are A gamma fibers. A gamma fibers are efferent to muscle spindles and they basically mediate muscle tone. A delta fibers are afferent sensory nerves. And they mediate temperature, cold, pain and touch. A gamma fibers are efferent to muscle spindles, right? So what is the sensitivity of these fibers, all the A fibers, to local anesthetic agents? Sensitivity of A fibers to local anesthetic agents is A gamma, A delta, A beta equal to A alpha. So this is the sensitivity of A fibers to local anesthetic agents. A gamma, that is efferent to muscle spindles, are the most sensitive to local anesthetic, then A delta, then A beta and then A alpha. Now as far as B fibers are concerned, B fibers are autonomic preganglionic fibers, and they mediate various autonomic functions. While C fibers are again divided into 2 types. One are dorsal root fibers. Now dorsal root fibers are afferent sensory nerves. And these mediate temperature, that is warm temperature, pain and touch. These mediate temperature, warm temperature, that is pain and touch. While C fibers are The second type of C fibers are postganglionic sympathetic fibers. Second type of C fibers are postganglionic sympathetic fibers, postganglionic sympathetic fibers, and they mediate various autonomic functions. So what is the sensitivity of these fibers to local anesthetic agents? Now sensitivity of these fibers to local anesthetic agents is B, C and A. Overall sensitivity is B, C and A. B fibers are more sensitive to local anesthetic blockade than C fibers, while A fibers are least sensitive to local anesthetic blockade. Reason being A alpha and A beta are very thick fibers. So that is the overall sensitivity, B, C and A. So answer to question number 4 is A delta. A delta are afferent sensory nerves, and these are more sensitive than the C fibers. C fibers are also afferent sensory nerves, but when you compare A delta with C fibers, A delta fibers are more prone to the local anesthetic blockade than the C fibers. Now question number 5. Baroreflex mechanism is altered by. Now baroreflex mechanism is altered by propofol. It is altered by propofol. Now propofol is also known as 2,6-diisopropylphenol. It is also known, this is the chemical name of propofol. Sometimes they ask you what is 2,6-diisopropylphenol. It is 2,6-diisopropylphenol is propofol. It comes as 1 and 2% emulsion. Now it consists of soybean oil, glycerol and egg lecithin. It consists of soybean oil, glycerol and egg lecithin. Now all these are organic compounds, and therefore propofol is a good culture medium for bacterial growth. It is a good culture medium for bacterial growth. Open wala propofol is discarded after 6 hours. Open wala propofol is discarded after 6 hours. So either you use it or you discard it after 6 hours. Now propofol causes pain on injection. It causes pain on injection, which can be decreased by mixing it with lignocaine. Now propofol is drug of choice for daycare surgery, neurosurgery. It is drug of choice for daycare surgery, neurosurgery, TIVA, patients with known history of malignant hyperthermia, drug of choice for patients with known history of malignant hyperthermia, drug of choice for liver disease patients, and for LMA insertion. Drug of choice for liver disease patients for LMA insertion. Now then so what are the systemic effects of propofol? Now in the cardiovascular system, propofol causes a fall in blood pressure which may not be associated with tachycardia. Normally, a fall in blood pressure causes a rise in heart rate. But in case of propofol, the fall in blood pressure may not be associated with tachycardia. Why? Because it blunts carotid body receptor response. it blunts carotid body receptor response, that is the baroreceptor mechanism. So baroreflex mechanism is altered by propofol. Now propofol, it causes apnea longer than thiopentone. It causes apnea longer than thiopentone. It causes maximum depression of upper airway reflexes. It causes maximum depression of upper airway reflexes. Now propofol is anticonvulsant. Propofol is anticonvulsant, although it causes myoclonic reactions, but it is anticonvulsant. It is antiemetic, it is antipruritic, and it is antioxidant. Right? So propofol is anticonvulsant, antiemetic, antipruritic, and antioxidant. These are all the things which are associated with propofol. It causes a decrease in ICP and cerebral metabolic rate. It causes decrease in ICP and cerebral metabolic rate. So these are decreased with the propofol. So answer to question number 5 is A. Baroreflex mechanism is altered by propofol. Now question number 6. Not correct about desfluranase. Now all of you know that desflurane is a fluorinated agent and it is a ether. So unlike halothane, which is a alkane, desflurane is a ether. Right? It is a fluorinated methyl ethyl ether. Now desflurane has lowest blood gas coefficient among fluorinated agents. It has lowest blood gas coefficient among fluorinated agents, that is 0.42. Now the lowest blood gas coefficient among all inhalational agents is xenon, 0.17. Lowest blood gas coefficient among all agents is xenon. Lowest blood gas coefficient among fluorinated agent is desflurane. Now please remember, lower the blood gas coefficient, faster is the induction and recovery. Now desflurane is most pungent smelling. It is most pungent smelling inhalational agent. Desflurane is most pungent smelling inhalational agent. It has a MAC of 6.6 in 100% oxygen and 2.3 in 66% nitrous oxide. It has a MAC of 6.6 in 100% oxygen and 2.3 in 66% nitrous oxide. Now, what does MAC denotes? Now, MAC denotes the potency of the anesthetic agent. And since desflurane is less potent than isoflurane, so MAC of desflurane is higher. MAC is higher than isoflurane. MAC is higher than isoflurane. So it is not lower than isoflurane, it is higher than isoflurane. And higher the MAC means weak anesthetic agent. Lower the MAC means potent anesthetic agent. So it is when comparison to isoflurane, it is a weak anesthetic agent. Now, sudden increase in desflurane concentration causes hypertension and tachycardia. Sudden increase in desflurane concentration causes hypertension and tachycardia. it is minimally metabolized, less than 0.1%. Desferrin is minimally metabolized, less than 0.1%, and it causes maximum greenhouse effect among anesthetic fluorinated agents. Maximum greenhouse effect among fluorinated agents. It causes maximum greenhouse effect among fluorinated agents. Now, desferrin, it reacts with dry carbon dioxide absorbent, to forms high levels of carbon monoxide. It reacts with dry carbon dioxide absorbents to form high levels of carbon monoxide. Right? So all these are the points which are associated with desferrin. So answer to question number 6 is C. MAC is lower than isoflurane is a wrong statement. It is higher than isoflurane. Now, question number 7. Shortest acting local anesthetic for subarachnoid injection is. Now, procaine has got short duration of action. Procaine has short duration of action. It is local anesthetic of choice in patients with history of malignant hyperthermia. It is local anesthetic of choice in patients with history of malignant hyperthermia. Lignocaine, it is used as a 5% heavy for spinal anesthesia. It is used as 5% heavy for spinal anesthesia. Then mepivacaine. Now both lignocaine and mepivacaine are intermediate acting. They are intermediate acting. Right? So procaine is has got shortest duration. Lignocaine and mepivacaine are intermediate acting. On the other hand, bupivacaine is used as 0.5% heavy. It is used as 0.5% heavy, and it has got long duration. It has got long duration. Now, then other drugs having long duration are etidocaine, ropivacaine, and debucaine. Other drugs having long duration are etidocaine, ropivacaine, and debucaine. Now, of all these drugs, bupivacaine is most cardiotoxic. Bupivacaine is most cardiotoxic. It shows differential sensory blockade. It shows differential sensory blockade. Sometimes they ask differential sensory blockade occurs with. It occurs with bupivacaine. That is, at a lower concentration it only causes sensory block, but at a higher concentration it causes both sensory as well as motor block. So that it occurs only with bupivacaine. So answer to question number 7 is B, procaine. It is the shortest acting local anesthetic for spinal anesthesia. Question number 8. Choose the most appropriate statement regarding post-dural puncture headache. Now, as all of you know that post-dural puncture headache or PDPH, it occurs 12 to 24 hours after spinal anesthesia. It occurs 12 to 24 hours after spinal anesthesia. It occurs due to leakage of CSF from dural puncture site. Leakage of CSF from dural puncture site. It is a low pressure headache. So, unlike meningitis, which is a high pressure headache, this one is a low pressure headache. Now, it is a low pressure headache. Now, the headache is usually occipital but may be frontal. The headache is usually occipital but may be frontal. Now, the headache increases in sitting and standing position. The headache increases in sitting and standing position and decreases in lying down position. So, when the patient will sit or stand, he will complain of increased headache. But when the patient will lie down, the headache will decrease. So, this is very characteristic of this headache. This is, you can say, the hallmark of this headache. Now, the headache can be prevented. The headache can be prevented, one, by using pencil tip needles. Headache can be prevented by using pencil tip needles, by using higher gauge needles. Higher gauge needles. Most commonly these days it is 25 gauge which is used, which has got a very less incidence. By using higher gauge needles, then adequate hydration, because the CSF production depends upon the hydration status, so adequate hydration is very important. Now, treatment, it consists of analgesics, bed rest, correction of dehydration, and most definitive treatment is epidural blood patch. Most definitive treatment is epidural blood patch. So what you do is you take 15 to 20 ml of blood from the antecubital fossa and you inject it into the epidural space at the same level. So the blood will clot and it forms a seal over the dural puncture site. So this is the treatment of choice for post-dural puncture headache. Now, the post-dural puncture headache is more commonly occurs in females. It occurs more commonly in females than males. It occurs more commonly in young than old. It occurs more commonly in females than males. It occurs more commonly in young than old. It occurs more common with multiple punctures than single puncture. It occurs more common in multiple puncture than single puncture. It occurs more commonly in pregnancy than non-pregnant patients. It occurs more commonly in pregnant patients than non-pregnant patients, right? So these are the few points which are important for post-dural puncture headache. Now, question number 9. So answer to question number 8 is diplopia and tinnitus may occur, which can occur with post-dural puncture headache. These are the neurological symptoms which can occur with the post-dural puncture headache. Now, question number 9. Infant or non-human milk, nil per oral period is. Now, patient is nil per oral before surgery to decrease the chances of aspiration. To decrease the chances of aspiration. Right? Now, in an adult patient, the nil per oral period for solids is 6 hours and for clear liquid is 4 hours. Solid 6 hours and clear liquid 4 hours. So the minimum nil per oral period in adults is 6 hours. If nothing is given, or solid or liquid, if they just ask you what should be the minimum nil per oral period in adults, that should be 6 hours. Now, in a breastfeeding infant, it is 4 hours for solids and 2 hours for clear liquid. In a breastfeeding infant, it is 4 hours for solids and 2 hours for clear liquid. Now, if the infant is on formula feed, or non-human milk, then it is 6 hours. If the infant is on formula feed or non-human milk, then the minimum nil per oral period will be 6 hours. Now, aspiration in pregnancy is known as Mendelssohn syndrome. Aspiration in pregnancy is known as Mendelssohn syndrome. Now, there are two criteria for Mendelssohn syndrome. One, the pH of aspirate should be less than 2.5, and second, the volume of aspirate should be more than 25 ml. The pH of aspirate should be less than 2.5, and second, volume should be more than 25 ml. So these are the two criteria for the Mendelssohn syndrome. Now, question number 10. In patients with advanced airway, breath rate during CPR is. Now, CPR stands for cardiopulmonary resuscitation. The sequence for CPR is compressions, airway, and breathing. Sequence for CPR is compressions, airway, and breathing. Now, the compressions are given in adults at a rate of 100 to 120 per minute, in children and infants at a rate of 100 per minute, and in neonates at a rate of 90 per minute. Right? So, in adults it is given at a rate of 100 to 120 per minute, in children and infants 100 per minute, and in neonates 90 per minute. Now, what is compression to ventilation ratio? For adults it is 30:2. For children it is 30:2 with a single rescuer and 15:2 with a double rescuer. So, if there is one person to save, it is 30:2. If there are two persons, then it is 15:2. For neonates, it is 3:1. For neonates, it is 3:1. What should be the depth of compression? Now, depth of compression for adults is at more than 2 inches. For children, more than 1.5 inches. And for neonates, 1/3 of anterior posterior diameter. Right? So, for adults it is more than 2 inches, in children 1.5 inches, more than 1.5 inches, and in neonates 1/3 of anterior posterior diameter. Now, the drug of choice for CPR is adrenaline IV 1:10,000, 1 milligram every 3 to 5 minutes. Drug out dose is choice for CPR is adrenaline IV 1:10,000 1 milligram every 3 to 5 minutes. Atropine, calcium and vasopressin are not part of routine CPR. So they should not be given routinely. They should only be given if there is an indication. So atropine, calcium and vasopressin are not part of routine CPR. For example, if the patient is having bradycardia, only then atropine will be given. Otherwise, atropine will not be used. Now, if the child is intubated or is having an advanced airway, then the breath rate is 8 to 10 per minute. If the child is intubated or having an advanced airway, then the breath rate will be 8 to 10 per minute. Hyperventilation should be avoided. Hyperventilation should be avoided. Hyperventilation is to be avoided. Glucose containing fluids should not be used. Or dextrose containing fluids should not be used during CPR. Dextrose containing fluids should not be used during CPR as they worsen the outcome of ischemic neurological injury. As they worsen the outcome of ischemic neurological injury. Worsen the outcome of ischemic neurological injury. Now, the most common rib fractures are 3, 4 and 5 left side. Most common rib fractures are 3, 4 and 5 on the left side. Those are the rib fractures which are most common. In any trauma, you will follow ABC protocol. And in case of trauma, the first step to be done is secure the cervical spine by cervical collar. Secure cervical spine by cervical collar. So you will apply as soon as you arrive at the scene of the trauma. The first step is to just put the cervical collar and secure the cervical spine. In severe maxillofacial injuries, cricotherotomy or tracheostomy should be done. In severe maxillofacial injuries, cricotherotomy or tracheostomy should be done. It may not be possible to intubate the patient, especially nasal and oral, right? And not the normal but the severe maxillofacial injuries, then you will go for the cricotherotomy or tracheostomy. So answer to question number 10 is B, 8 to 10 per minute is B, 8 to 10 per minute.